thought it'd be a good presentation. Oh, are you recording? I thought it'd be a good kind of refresher for some people, or just kind of explanation about what we're doing here and kind of why we started this practice like this. Sorry, I'm watching my wife not fall. So the kind of practice that we have here, that we started here, that Rooted Family Health is what's called a direct primary care. So I wanted just to kind of have a discussion with people just about what that is, how it could be helpful and beneficial for people, and kind of how it's different from what a lot of people have been used to for their how they've received healthcare. So to start off with, what are some of the problems of healthcare today? So I thought instead of me just kind of listing what I think are the problems, I wanted to hear from you guys, just real quickly, a word or two, what you guys have experienced or see as the problems with healthcare today.
The inability to get in at a reasonable time.
Okay.
They usually have you 3 months out.
Okay. Anything else?
Well, I've got one. Even with that wait time, because of all of the other things that physicians have got to do in today's world, they don't get to spend the time with the patients. Before I got the opportunity to have a doctor in this kind of practice, I'd go in and you get the receptionist, and they'd have you fill out a bunch of stuff. And then if you were lucky, you'd get to see the office nurse, maybe 45 minutes to an hour later, and you tell them what you thought was wrong, and they would nod wisely and say, well, let's either nod wisely and say, well, the doctor will need to see you in a few minutes, or they would deflect. It's either something that they didn't know enough about, or they knew the doctor didn't want to mess with, or whatever, and you never did get to see the doctor.
Good.
And a lot of doctors are not taking Medicare. Really? I didn't realize that.
Would
They're
you
not
sum
doing
it
what?
up by saying it's dominated by, or dictated by the hospitals and insurance companies?
Mm-hmm.
Oh, yeah.
To me, it seems more like sick care, whereas
Mhm.
this seems more like well care, keeping the patients healthy, so we're not having to push.
Yeah, you're proactive, and I
Yes.
just kind of, they don't even respond.
Okay, well, I'll go through some of the ones that I came up with. It is kind of interesting, no one said anything about cost. So, the cost of healthcare is a big problem that a lot of people are dealing with. Access, kind of what we had talked about, just getting in at a reasonable time and being able to see the doctor that you want to see. I said communication, that could be kind of what Rick was talking about, just about being able to have that, personal communication, and being able to communicate what you're coming into the doctor for, and then sometimes have to repeat it, and they might not really understand what you're talking about. Confusion, just with the whole process, kind of, you see the receptionist, you see the nurse, you wait, and it's just, and then you check out, and then the whole process of going to see a doctor is very confusing, and I did it for 20 years like that, so.
I have another one. Because they have so many patients, it's happened to me that there are 2 or 3 other people with the same name as me. And that's, I don't like that.
Yeah.
That's happened.
Yes, definitely. So time, just kind of a lot of you guys mentioned that
Yeah.
long waits, the short office visits, just time in general, I think is a big problem with how we're doing healthcare in this country most of the time. And then the insurance companies, what as Mary was saying, insurance companies kind of have control of the bureaucracy A big part of why I ended up changing was because I felt like I was no longer working for my patients. I was working for the hospital systems and doing what they wanted me to do, or the insurance companies, including Medicare, giving us all these criteria or things that we had to do before we could actually listen to the patient and kind of work on solving their problem. So to defend them a little bit, yes.
Do we
I
have
was
to?
just gonna mention, I didn't know if you're gonna mention meds, but to get meds for those who have reoccurring on a timely basis and, you know, because if you have to order, for example, we go up to Canada, I have to order meds for a couple months in advance, and it's getting increasingly difficult to do that. If you get, they'll say, we received your order and your order's canceled. Well, thank you. So,
Yeah.
it's hard to get.
Yeah, that could fall under that access.
Yeah,
Being
the
able to
access.
access, yeah.
Yeah.
For the meds.
Or even communication.
Or
being able to get
communication.
through.
Also, they may say, well, I'm concerned it may be blah blah and we need tests. The nurse will schedule you. You go to or the receptionist, you go to be scheduled. Well, no one can take you for 3 months.
Yeah.
Yeah, that's the access.
Yeah, and some of that is still going to be a problem even for me too, because getting access to other things. If we have to send someone to a specialist or get a test done, if there's still backlog, there's still going to be backlog with me as from when we send people to get things done too. But to defend some of the hospital systems, at one point there were good ideas. Someone had a good idea that if we did things this way, it might help the system. But then when you just have too many hands in the pot and there was a graph that I was looking at when I was preparing for this, the growth in hospitals against the growth in the growth in doctors against the growth in hospital administrators over the past 10 years, and it's amazing how many hospital administrators there are versus the very small growth in doctors over the past decade. So, not very good. So another thing with insurance companies, insurance-based, where I practiced for 20 years, insurance-based practices are based on volume. So the only way they're going to grow the practice and make more money so that more people can get care and everything like that is they have to see more patients. And so that's how come sometimes you feel like you're just herded in somewhere and herded out, because they're trying to get as many patients through as possible, get as many office visits in, and
So they can get money.
so they can get money so that they can help the system, because if we believe that the system so whether it's St. Joseph's or Scott and White or whatever health system has people's good in mind, then we need to help the system. And so that's to their defense. That's kind of what they see as the goal. If we can keep the thing going, then eventually it's going to help more and more people. The other big difference between what we do in this kind of practice versus insurance-based systems, the system, again, whatever healthcare system it is, doesn't make a lot of money from primary care providers. They make more money from specialists and from procedures that are done. So if you ever hear people talk about primary care providers as gatekeepers, our goal is to keep that gate wide open. And so what they want us to do as primary care providers is see as many people as possible and then refer. And so you're just kind of this gate, just blowing people into the system to refer, so that there are more expensive things that can get done. That they might do a good job. I mean, a specialist might do a really good job at different things, better than me. But sometimes, if the primary care provider just had a little bit more time with the patient, maybe we could solve some of those problems and not have to refer, not just automatically refer everyone to a specialist or for a test or something like that. And so that's kind of the last thing there, the socialization of healthcare. In my conspiracy theory brain, I feel like this has been someone's plan for decades to try to get the healthcare system so bad and so out of control and unfixable that the government's going to swoop in and just save the day. And that's kind of where we are.
Government save the day, I don't.
Which is funny, do we really want this government?
Well, I mean, it depends on who you ask. I feel like there are a lot of people that they feel like, you know, when you're choosing between free health care from the government versus spending $2,000 a month on health insurance, they'll probably take the free health care. If they see those as the only two options. But that's our hope in starting this DPC, that we can help provide other options besides those two. So how does direct primary care solve these problems? So I listed some out there. So remove insurance companies from the picture as much as possible. You know, it's not possible we're not going to be able to get rid of insurance companies all 100%, because probably most of you sitting out here have some degree of insurance coverage. And we want you to have insurance coverage, but more for the purpose of what insurance was built for. You know, if you end up in the hospital or need an MRI or, you know, need your gallbladder taken out, I'm not going to be able to do those kinds of things for you. So we want you to have that kind of coverage to help you. And so we work with the insurance companies as much as we can, you know, to get things approved. That's why we hired Nancy. She's kind of the expert to do things like that, and is very helpful. So monthly membership fees is the next thing. So as opposed to, you know, paying these high insurance premiums, the monthly membership fee that we charge people just makes things a lot more simple, and makes things transparent. People know exactly what they're getting. Part of that confusion with the problems of the healthcare system is you pay this money and then you don't really know what you get. And then you go to the doctor and then you pay a copay, and then all of a sudden you get a bill for something that you're not sure what that was for. And so, and no one really knows. I mean, I've been sent to collection agencies twice for not knowing what it was that I was paying for. And so it's very confusing, and no one can really give you a straight answer as far as where that dollar is going. And so with direct primary care, we hope that everyone knows where that dollar is going and what it's getting. There actually are laws now for hospitals and radiology places. I think it's called the Sunshine Act. No, it's a different act where there's transparency in cost of things. So when you're getting an MRI or a CAT scan or something like that, you know exactly what they're charging you. So that is always a good thing. So the other thing that we think the monthly membership fee does is it kind of restores that doctor-patient relationship. So you'll hear a lot when you read things about direct primary care that the insurance companies are the middleman. And that was kind of the goal when insurance companies came about, was I think it's because doctors got greedy. So doctors got greedy, they started raising their prices more and more, and then there was just not consistency. You could go to this doctor and they would charge you this much, you go to a doctor across town and they charge you this much. And so because things got out of control, HMOs and insurance companies came about to try to kind of cost control things. And they became the middleman, and then the doctors ended up working for insurance companies, and patients became basically the commodity. So patients were no longer the consumer of healthcare, patients were the commodity of the healthcare system, to where doctors and the insurance companies were working together for, you know, whatever we could do for these commodities, which are patients. Which isn't it's not a very friendly approach to healthcare, doing it that way. And then the easier access, you know, I think the monthly membership fee, it just allows for things to just be simple. I don't have to have the 3,000 patients that I did at the other practice, And so I can keep my practice smaller, so when patients call, you know, we can get people in sooner, people can communicate with me easier, they can email or text me, and so that the simple membership fee helps a lot with that. And again, the shorter waits, longer office visits. And then free market is another word that you'll hear a lot when you read things about direct primary care, kind of opposed to the socialization of healthcare, where the government kind of takes over things. Direct primary care practices really want to use the free market system. So I want to add as much value to my practice for you guys, so that whatever monthly fee you're paying, that you're getting as much value out of it as possible. Whereas the insurance-based practices, they're just going to do whatever it takes to keep seeing patients. And they don't really have to add value to what they do, because the insurance companies are going to keep funneling patients to them. So just like everything else with socialization, there's no competition, there's no incentive to try to do better or be better or sell your product. And so with direct primary care, I understand that from one month to the next, you guys can decide you want to go somewhere else. You know, a patient might decide they see another product, another practice down the street or across town that's doing more of what you want, and then patients can leave. And which is fine. I mean, I think we really appreciate that. Dr. Rice is another doctor that does a direct primary care here in town, and she does OB and sees a lot more little kids because she delivers babies. And so someone who wants to do something like that might want to go over to Dr. Rice. And so it's not that I'm going to start delivering babies again, but patients can choose, and we want patients to be able to have that right to choose and the ability to kind of have the choice to go where they want to go. I thought this was a fun little video if you guys want to watch it.
Takes her sons to the doctor. She doesn't worry about feeling rushed.
Takes as much time as it needs, maybe 30, 45 minutes if needed.
And you say, ah.
A big reason she opted for something called direct primary care instead of traditional insurance. It's a membership of sorts. Unlimited visits with Dr. David Cunningham for a monthly flat fee. She can text or call anytime, which can be often with a 2-year-old prone to ear infections and a 4-year-old with asthma.
What does it feel like when you have asthma?
Tight. Tight? The fee is typically between $25 and $85 a month, depending on your age, for unlimited visits, routine lab tests, and some plans even cover prescriptions. Jenna's family saves $500 a month with direct primary care and a less expensive high-deductible plan for other medical expenses. Dr. Cunningham left a traditional practice. He sees fewer patients and makes less money, but says it's worth it to avoid insurance companies dictating how he treats patients.
It feels great to be practicing medicine the way it's supposed to be.
Critics warn there's already a shortage of primary care doctors, and direct primary care does not cover specialists or hospital stays.
That leaves this whole mid-range of health problems that really can't be addressed in even the best of primary care physicians and haven't quite reached the threshold for catastrophic insurance.
But for the Nelsons, direct primary care is the answer to save money and have a doctor who's always in. Kristen Dahlgren, NBC News, Mansfield, Massachusetts.
NBC News fans.
So I thought that was a good little presentation of how it works, and it's not for everyone. I mean, I think for the majority of people, it can be something that could be helpful and good and better than the alternative. So there are some, I don't know if you can see that from back there, this isn't a great slide. So there are lots of questions about direct primary care as it's growing. So right now, 9% of primary care, of family doctors are in a direct primary care right now.
Oh.
And so they're more
In the nation?
in the nation.
How many?
9%.
9%.
So and it's growing
9%.
just because of everyone's frustrated. The doctors are frustrated, the patients are frustrated. There has to be some alternative to how we're providing, called delivering healthcare to patients, and so I think it's going to continue to grow. But there are always questions. This one person posed was, why would someone pay a monthly fee for healthcare when they are healthy and don't use it each month? And which is a really good question. I mean,
You do the same for insurance.
you do the same for insurance. You know, it is interesting because with insurance, I mean, this is how I always feel. I hate paying for insurance, but I have to. Is you pay for insurance and then you don't want to use it. You do whatever you can to not use your insurance, but you're willing to pay all that money out every month for insurance that you just don't want to use. And so.
But don't they also raise your rate
If you use it. Well, health insurance they don't, but yeah,
Any
car
other
insurance and home
yeah.
insurance, yes.
Or they say we can't cover you anymore. You
Right.
only get so many.
Yeah.
That's it.
Yes, Scott.
Yeah, so the video clip said that they were saving $500 a month. So I guess that's the difference between the fee that they're being charged by the DPC and what they were paying for traditional insurance.
Probably. Yeah.
Is that where that comes from?
That
Because they could
is.
do a higher deductible insurance plan because all of their primary
Yeah.
care needs are met.
Yeah, I understand they
Yeah.
went to more of a catastrophic sort of plan, it sounded
Exactly.
like, which is cheaper. So I guess when you factor all that in, they're saving money.
Mhm.
They still got a premium, insurance premium they're dealing with.
Right.
It's a lower premium than their traditional insurance was,
Yeah.
even with the DPC.
Yeah, and especially if they have kids that have a lot of office visits, they don't have
Yeah.
co-pays that they have to pay.
Mhm.
Yeah.
So it's really, you know, when I first learned about DPC about 7 or 8 years ago, they were really touting it as saving everyone money. It doesn't always save people money. You know, in some situations, people might end up having to pay a little bit more for a direct primary care practice. I do think if you can work things out correctly, it will save most people money, but I don't think it'll save everybody money. Especially if you have free healthcare. If you have Medicaid, it definitely won't save you money because that's free.
How does this, how do these,
Yeah, right.
how does the equation work with Medicare?
With Medicare,
Yeah.
I mean, the Medicare has gotten so complicated now too that I don't know how to answer that because there's so many different plans of Medicare. So I think it depends on what Medicare plan you choose, whether it can actually save you money. So, I mean, otherwise, because with Medicare you don't typically pay a copay for office visits, or do you?
I don't, this may help you, I don't pay for him, but at the same time, we run into that problem that he's talking about, they schedule 3 months out, or you're there at 9 o'clock and they don't see you till 10:30.
Right.
And then you have, various things like that, so to me, not only that, I've been with you for quite a long time, it was like, this guy doesn't care. So, or that's the impression I get, this doctor doesn't care.
Yeah.
So it's worth it to me to go ahead, I'm losing money, I know that. And it's worth it to me to pay you, this way I see you when I need to see you.
Yeah.
I mean, a couple of days maybe at tops.
Yeah, and part, again, having a smaller practice, that does help that, I can be more familiar with all of the patients and instead of just whenever I see you once a year or twice a year or something
Well,
like
and
that.
like you said, some people aren't accepting Medicare anymore, or Medicaid. A lot of people don't accept Medicaid anymore, and so you're stuck with, where do I go see a doctor?
But if you have the quarters, you don't have to pay Medicare. Since I don't have the quarters, I've gotta pay quarterly $524. It's been going up. So I gotta pay every quarter $524, or I could pay monthly.
Yeah.
And but because I'm older in age, and you never know what else is gonna be happening.
Falling apart.
Yeah, maintenance, they look like the car.
So this person, her answer was, when it comes to primary care, I find that most patients want access to appointments in a timely fashion, to see their doctor, someone who knows them, and not simply someone filling in for the shift. enough time to address their concerns and not feel brushed off or rushed. Appointments that start on time without being herded and a waiting room or forgotten about in an exam room. So she said, and this is a direct primary care doctor. She says it's paying for a commitment between the doctor and the patient. It says that I will be here for you when you need me the most.
That's
so,
peace of mind.
Yeah.
That's exactly what we're all searching for.
Right. So kind of a corny thing I came up with. I can't believe I'm even saying this. But instead of paying for insurance, you're paying for assurance. And so that assurance that there's someone who's gonna care, someone who's gonna be able to take care of you, and we've seen that over the past year and a half of doing this, that sometimes I wonder, like, why are they still coming? Why are they still paying? And it's because they want that assurance that they're gonna be taken well cared of.
But it's a gamble. Paying insurance to me is like a gamble. You might use it or you might not. The same thing with long-term care. Let's say you die and all that money that you paid in, you didn't use because you died earlier.
Right.
I mean, it's just a gamble.
Yeah. It is. I mean, and that's what people, they want us to try to guess, you know, and it is, it's hard to know what to do with that money, if there's better ways to put it away so that your kids have it to take care of you or something like that, but yeah, I don't know what the right answer is for that. So another question is, I already have insurance, this is kind of what we're already talking about. I already have insurance, why would I pay more to see a doctor? I can't even read that on my screen. And it says, this individual called because he struggled to get an appointment with his current primary care doctor and always had to go to urgent care centers. Here are 2 simple reasons to make the switch to DPC. Same day, next day appointments. Number 2, time with your doctor to address all your health concerns. A doctor running a traditional insurance reimbursed primary care practice cannot offer that. They are operating on a volume, not value model of care. They spend 7 minutes with you and then you can't see them again for weeks or months. And if you're sick, your only option is urgent care or the ER. Why? Because health insurance companies are making record profits on paying less, denying more, and charging higher premiums. As a primary care provider, I can provide you excellent care or I can take your health insurance. I cannot do both. So I thought that was a good answer. That's another DPC doctor.
Dr. Imperial, if I might, just a little story. We moved down here from up in the Pacific Northwest about 3.5 years ago. We had lived in Texas before, but moved back there because my wife had grown up there. Came back down here, and I'm not going to tell you which group I was with, but it was one of the big hospital groups, and they assigned me to a primary care physician, okay? And he wanted me to be in there once a year for my annual appointment. And I went in, the initial appointment, he got me in there, they had me fill out a bunch of forms about my health, and then he sat down to see me. And he was sitting at a computer screen. And he had a long list of questions because he wanted my history, and he spent about 45 minutes on that first appointment, never made eye contact with me even once. He was asking me a question, I give him an answer, and he typed in the answer on his screen, asked me the next question, which was also reading that question off the screen. And I spent 45 minutes with him, you know, excuse me for saying it this way, playing with his computer. I stayed with him before we managed to find you. I was with him for basically 2 years. I never had an appointment with him where he made eye contact with me. Not once.
So it's funny you bring up the Pacific Northwest because they think that this direct primary care idea started in the Pacific Northwest.
We have primary care up there.
Yeah, we were in a primary care practice up there, but it wasn't this one.
Yeah.
I don't know who that is.
So this is called Seattle Medical Associates back in 1997, Dr. Garrison Bliss. And he talks, I don't have to read the whole thing, but he basically talks about that it should be the patients that are making the decisions as far as who they want to see and what kind of care that they want. I will read this. It says, the level of physician dissatisfaction is an all-time high despite our enormous incomes. We blame the insurers and government for ruining our profession, but it is we who are to blame for allowing our decisions to be corrupted. We sign the contracts and we live by the rules of our financial entanglements. So he really feels like, because we basically got in bed with insurance companies and bureaucracies that, we lost our ability to kind of regain this kind of doctor-patient relationship and trust in patients. So whenever I was thinking of starting this practice, my idea wasn't to, flip over the whole healthcare system in the United States, but there are a couple of words that you'll also hear and read about when you read about direct primary care. They're innovative and disruptive. I think a lot of people are using that word disruptive now. And so if I could just make a little ripple in this community and just get people to start thinking that there are other options besides, the free government health care and the $2,000 a month health care, that there are other ways that we can kind of work on fixing this problem and providing good health care for patients.
Dr. Imperial, I know you're a pioneer in this area in direct primary care. Are there many of you? Do you see more coming into it?
So there are. So actually the pioneer for this community back in 2015, Dr. John David Heiser opened a direct primary care over at the Physician Center. And so he's still practicing. He has a couple of urgent care centers too that he runs as well. And so that his primary care practice isn't his only practice. Wesley Rice, she's a female. She worked with me at St. Joe's for a long time, and then she started her direct primary care about 3 years ago, and she's done really well. Dr. David Heiser is full, Dr. Rice is full. And then you may have heard of Doc is Here. It's a practice around town that does home visits. They do only home visits. You can pay for just the individual care, just their team to come out and see you, or you can pay for a membership for them also. So those three have been here for years, and then so as far as we know, I'm the fourth. There is another doctor, so there are different things that you'll hear about with direct primary care, and people will call them pure DPC. Pure DPC basically is they don't take insurance at all. They don't bill insurance, they've opted out of insurance companies, and so there's none of this entanglement that Dr. Bliss was talking about. And then there are some hybrid DPCs that do both. They'll charge a membership, but they'll also do some things that they'll charge insurance too. I feel like that just muddles the matter. It just seems confusing to me. And so another term that you'll hear that gets confused with DPC is concierge medicine. So that's been around for a long time, and the one reason why they kind of came out with DPC is they feel like DPC is concierge medicine for everyone, where concierge medicine was just for the rich and wealthy and people who have just spare money laying around. DPC could be for anyone.
Well, in concierge, a lot of them mix those. They also bill insurance as well.
Yeah, they might also bill insurance as well.
That was one of the differences.
So, but of course with everything, there are downfalls. I mean, DPC isn't perfect. So I listed some there. I'm sure you guys can think of others. One thing, I feel like direct primary care practices, because they're usually small, they're usually one or two providers in a practice. There are some big ones that are coming out. Actually, Amazon purchased a practice for several $1 billion that are doing a hybrid DPC. I don't think it's working very well for them right now, but so there are lots of these other things that are coming out. But in general, DPCs are limited by the provider, by the doctor, or some nurse practitioners have DPC practices, and so the practice is only as good as who's providing the care. So if you go to a DPC doctor and, you know, they, I don't know, they don't do sutures, or, you know, different things like that, then it kind of, you're limited the kind of care that you can get. And so if you cut yourself, you have to end up going to the urgent care center anyway. So one thing they're really, whenever we go to these conferences, they're really encouraging us to relearn how to do as much as possible. Because when we finished medical school and residency, we could do everything. But then over time, you kind of either specialize yourself, or you end up, it takes too long to try to work on this thing, and so you just refer them to the dermatologist or somewhere else like that. So you heard that one doctor talk about on the video, this next one, what if all PCPs go into DPC practices? There are a lot of people in the country, and we would need a lot more doctors, a lot more primary care doctors, if everyone did this kind of model. I think it is possible, but I don't think it's probable that all the doctors will go to direct primary care practices. What I could see happening is, you know, a lot of countries in the world, you have kind of government doctors and you have private doctors. I can see that happening probably, you know, even in the next few years. If socialized medicine kind of pushes through, then there'll be other doctors who might be more some sort of direct primary care where you pay directly to them, and then there'll be these government doctors taking care of other people, free healthcare basically.
I don't know how to state this properly, but those free government doctors, are they gonna be like the ones that are coming out of that California school there where the DEI is real big, that doctor school?
I don't know, I haven't heard of that.
There's a doctor school in California that are pushing that DEI, and they know they're getting more quality doctors, and they're still pushing.
Yeah.
I'm wondering if the government doctors are gonna wind up after you're talking about.
I don't know. You know, how to manage referrals to specialists. There is a smaller movement of what's called DSC, direct specialty care, where some specialists will be involved in kind of a monthly membership plan like this too. How helpful that would be, it depends. So if someone has heart disease and they need to see their cardiologist several times a year, it might be helpful to be on a membership with that cardiologist. Or if you have lung disease and you have to see that specialist a lot. But if you're just seeing a specialist once or twice for an evaluation, having that membership with them wouldn't be that helpful. But I think there'll be some direct care planned, you know, doctors that are coming around more and more who are specialists, who are getting tired of dealing with insurance companies and bureaucracy. Like Amy. With gynecology. And so, I don't know if everyone has met Dr. Harold, who we added to the practice back October.
Okay.
So, she's a gynecologist here in town. There's actually a hospital up in Oklahoma that doesn't bill insurance for any of their procedures. And so they'll charge you a cash price, and including the doctor, the anesthesiologist, and everything, and the hospital stay and everything like that. So just not to deal with insurance companies.
May I ask a question? As I said, we were with a DPC practice up in Seattle, and we signed up with you as soon as we got a chance down here. When we first moved here, you weren't doing this yet. But most of the DPC doctors that I'm aware of have been in the big insured practice realm first. And as a result, they have really good connections with the hospitals and the people who are providing specialized care. If a DPC doctor was to start off trying to be a DPC doctor, how would that physician get the connections to know which specialist to refer to?
Yeah.
I mean, you already knew that stuff
right.
when you moved.
It would be difficult, and Dr. David Heiser did have a hard time with getting started, because he came right out of residency.
Oh.
You're right, because no one knew him, he didn't have, patients didn't know him, other doctors didn't know what he was doing. You know, at that time too, he kind of sold himself as a concierge practice, and so people kind of looked at him funny because he was this fringe doctor or something like that. And so he had a hard time growing and getting people to understand what he was doing, but he eventually got to where people understand it. And then he's been in the community, and then he was in the he's at the physician center. So the way they built the physician center, they're really trying to make it kind of a self-contained doctor practice, so you could have lots of different specialists there.
Yes.
So then he ended up learning and getting to know other specialists there as well. So, and then hospitalizations. So both the referrals and hospitalizations, I think the answer to those things is, you know, having some sort of catastrophic umbrella plan that will help you with those high costs. Kind of what insurance is supposed to be for. So, and that is all I have. Any other questions or?
Let's say, like, it hasn't happened to me, thank God, but let's say I have to go to the hospital. So then I'll just go straight to the hospital, and if they say, who's my doctor, then I tell them, you're my doctor, and then what happens? Then I tell them, well, I give them my insurance card, for sure.
Right.
And then?
So it's a really good question. So right now, the way that I'm doing hospitals, when my patients are hospitalized, both hospitals, St. Joe's and Scott and White, have hospitalist programs. So they have doctors there that will take care of you. So right now, if you end up having to go to the hospital, you do exactly that. Hopefully we'll have talks, you know, have a conversation or a visit about why you need to go to the hospital and everything like that, so that I would be aware. And then you go to the hospital and then be admitted if you needed something done, and then I'll be able to communicate. So I can still go to either of the hospitals and visit you, but I won't be the primary caregiver, or what they call an attending of your case there in the hospital. But I can.
Even if you have a regular doctor.
Yeah.
Right.
Does it work that way also?
Yeah.
Well, now it does. I mean, for years, we would see our own patients in the hospital. But you're right, once the hospital system started, they didn't want us in the hospital. They wanted their team to see you when you're in the hospital. So I'll be able to go visit you and then communicate with the hospital doctor and kind of coordinate care, so that at least you're seeing a familiar face and there's someone who knows you, who's involved in your care also.
And then, what about our records? Let's say they need our record of.
Medical records.
Yes, medical records.
So, I mean, again, they can call me and we can get medical records to them.
And they usually have you sign a sheet when you go to the hospital to get your records sent to your doctor.
But if they're in the system holds them up, but you're not in the system anymore, so
Right.
they have to contact you.
Yeah, so like it.
So Amy's my doctor, and so I was just in the hospital last week.
Oh, God.
And so I had to sign all those things, and I'm hoping they'll send it off to you.
But they're asking about the other way, for the
Oh, the
hospital
other way.
doctor to have access to your records. I mean, in reality, typically when you're in the hospital, they don't want all of your medical records.
They
You
got
know,
enough.
they're gonna get their information from what you tell them, and then if I'm gonna be involved, what I tell them also. But they typically don't want. Usually, what they'll want, what medical problems you have, and what medicines and allergies,
And what insurance, for
and
sure.
what insurance.
That's the first thing.
Yeah.
Well, what's your name first?
Are you limited in terms of referrals to who you can refer to?
No, actually, I'm less limited. So where I was before, they really want, again, the funnel system. Again, they really wanted us to funnel everything into the system, and now I can refer to anyone. So.
Any limitations from Medicare or anything, referring to specific doctors?
So I don't have any limitations. You know, so the insurance company might have, whoever's on your plan in network. So one issue that we've come across as far as insurance, not Medicare specifically, but with insurance, if there are any HMO plans. So the way HMO plans work is they're very restrictive. They're typically less expensive. The premiums are a lot less expensive. But because of that, they're very restrictive, and they have primary care providers that are assigned to you.
Yeah.
And so any referrals, any orders, anything like that has to be approved by their PCP that's been assigned to you.
Okay.
So where I realized that was some of the A&M plans are actually HMOs. Not all of them, but there's one that's called, maybe I should have listed. There's one that's a HMO that's very restrictive. And so you just want to look at your card and see, make sure it doesn't say HMO or Health Select.
But in practice, you haven't run up against any walls referring people who are covered by Medicare?
Not with Medicare, right?
Okay.
Yeah.
And you have our files. Where did our files go to? Like when we used to see you, you had our records. So do you have our records?
So probably, if we've had you sign a release and then St. Joe sent it to us, then I have everything. I'm working on getting access to St. Joe's system, but the problem is they're about to change, supposedly. The rumor is they're changing their EMR, so everything will change here soon. So.
Well, thank goodness you know us.
Yes.
Yeah.
You know us. We
Not
have,
just a number.
right, and we have had contact with you.
Yeah.
Eye contact with you. So,
Dr. Imperial, when we
Yes.
first came to you, you had a schedule of age and payment.
Uh-huh.
Can you give us that again?
Yes, uh-huh. And
It's on our website.
it hasn't changed.
It's on our website. But you can pull it up. And while he's pulling it up, I want to tell you, we have something coming up for the fall. So we are hopefully going to be able to sign on soon with this immunization company, who they will actually bill your insurance for you. But we have to give 250 immunizations on our own before they will let us join your company. And so we have ordered flu shots for this year. What did you say?
Sign me up.
And so we'll be doing flu shots, but we're gonna have to charge for the flu shots for this first year.
like how much?
Do we remember?
I don't know.
20, I think, between 20 and 40. Some of the flu shots that will last for over 65 for the whole year, those are a little bit more expensive. Actually, they're like 3 times the price. But so we'll have the flu shots. So we have that coming, and once we reach 200, 250, then we'll be able to provide any immunization here that will just be billed to your insurance. So, which is pretty fantastic. We're excited about it. So.
I find that interesting. The older we get, the less we pay per month.
That's
With
about-
that ratio, it usually increases.
Oh, yes.
with
Yes.
age.
This is about the first time that, yes.
I thought
Well,
we
has he
had
told
seen
you
that
why
right.
he did that?
I didn't ask.
So, do you guys want to know?
We won't be around that long.
No. So, this is always a hard thing as direct primary care doctors kind of come open their practice, is how much you're going to charge.
Yeah.
And you can look across the country, it's everything. I mean, there are people that charge $150 for everyone. One of the trends now is that they think this is even too confusing, that they want, they think it's better just to charge one flat rate for every life, and then not worry about this. The reason why I did this, one, 0 to 17-year-olds, my mentality, my idea, thinking behind this was more complexity. Maybe that's not the right word either. So they, 0 to 17-year-olds, even though they might have more office visits, they're usually not that complex, you know, little kids. And 18 to 39-year-olds, maybe there's a little bit more complexity in that age group, and they come in and might use more services and things like this. 40 to 64-year-olds, I feel like that is the highest maintenance age. Even though you might think that you're sicker when you're older, I feel like that, I've always felt like that age group consumes more healthcare services. Maybe, for me, for primary care. So across the board, definitely, the older you get, the more healthcare dollars you use, because you're taking more medicines, you're seeing more specialists, you're doing more things. But for primary care, I feel like this is the higher consumer of primary care services. The other thing is, this is usually the highest earning potential for patients between 40 and 64. And so they probably have more ability to pay a higher amount. And then at 65, you retire, most likely, and then you have more of a fixed income. So I felt like we could give people a break when they turn 65. Same thing, over 80, you know, this even less, more fixed income. And then for me as a primary care doctor, for most patients over 80, it's not as complex as this. Most people over 80, they're just kind of, you're coasting. My job for people over 80 is to keep you well.
To coast nicely.
Yes, and to coast as smoothly as possible, to kind of keep it from being as bumpy, if we can keep you from having, you know, to end up in the hospital and not worry about things like that. You know, maybe more of it over 80 is probably more hand-holding, because a lot of people have a lot of specialists that they're seeing that are taking care of a lot of their problems. And so it's more just being there to kind of interpret what the specialist is saying, or kind of walk you through different things like that.
Have you found this to be true, your theory?
I don't know. I mean, again, only a year and a half into it. It's hard to say. People question me about this a lot, even in other DPCs. They think I'm selling myself short for doing that, but what it did do is it did help my practice grow with the over 65 community. I felt like a lot of Medicare patients are more comfortable coming to me because they don't have to pay. A common thing, I've seen other practices that will do the same thing, and then over 65 they go to $150 a month for everyone over 65. The other thing is, I've always liked seeing geriatric patients, people over 65, and so I didn't mind going down. And I feel like when people end up charging more the older you get, it's because they just don't want to take care of those patients.
Yeah,
So
It feels that way
geriatric.
yeah,
many times.
so
But you have
that's
a great father-in-law. Who's amazing.
any other questions?
This is individuals plus family? Is there-
So, right, so for families, what we do, we don't have any special family plan, but we just cap it.
Okay.
So like, there's a so if there's a family of 2 parents and 4 children, we don't want to penalize them for having more kids. And so what we do is we just cap it at 275. So, so like I have a family of,
The 2 parents are probably in the 70.
yeah, maybe they're in the 70 or the $100.
Yeah.
But like if they have, I think I have a family of like 5 kids, and they're getting a steal because, you know, they're still only paying $275 for the whole family. All right. Well, again, thank you guys for all coming out. I feel like you guys were an easy audience for me. So.
It's interesting to understand, because I've just been a member, what, 3 months, 3-4 months, something like that. But the concept, of course, I knew you prior to, and when you lived over in Timbuktu, and we moved over here, which makes life much easier for me. But this seems like a good idea. I've enjoyed the concept so far.
It is a different, and one reason why I wanted to do a talk like this is because it is a totally different way of thinking about healthcare delivery, how we can take care of patients better. Because a lot of people think of DPC and they think it's not going to work, but they kind of use the insurance-based construct of healthcare and then just kind of apply DPC to it. So I'll end with this too, about the argument that there are too many patients. If people go to direct primary care and we all only take care of 600 patients each, we're going to run out of doctors, and there's already a shortage. My argument is, one, I think with direct primary care, we can take better care of patients to where they don't have as many needs, and they're not consuming as much of the healthcare dollars that are out there. Not needing to go to as many specialists, maybe not needing as many procedures and things like that, maybe. The other thing that I think would happen is it would attract more doctors to primary care. One argument, or one reason why a lot of people finishing medical school don't want to go to primary care is because it doesn't pay as much as cardiology or surgery or dermatology. So with this, if we could make it more attractive to doctors to do this kind of practice and still have a life and be satisfied with the practice, more doctors are going to want to come into primary care. The other thing I think it will do is I think it'll give longevity to doctors too. Instead of me thinking of retiring at 55, with the other practice, I feel like I could do this for a long time. And so that will help keep me taking care of my patients longer, and then as other new doctors come around. And so in the long run, decades down the road, I think we'll be fine if more and more people go into direct primary care. But it's hard to see that right now in looking at how we are.
It seems like it's a new concept.
It definitely is.
Fairly new,
Yeah.
so it'll take a while to iron the bugs out and for the public to become familiar with the concept.
But you're less stressed, aren't you?
Let's see.
Aren't you less stressed?
I think so. Ask my wife.
Yes, definitely.
I mean, you're happier.
I am happier.
You're happier because you're less stressed?
I think I am. I definitely think, I definitely, the work, so I can't say that I don't do work at home.
Right.
I was just reprimanding you.
Oh, okay.
But the work I feel like is more productive work and helpful for patients than the work that I was doing before when I would bring work home before. So.
Well, it's like me. I used to be a teacher for 35 years, and well, back then it was a lot better than it is now. So there was a lot of stress, but now that I just substitute, I can go when I want. They say, they want me to go every day. I say, why? I'm retired. I can just come when I want to. If I don't want to, I'm just reading, lying in bed, getting up when I want to. So I think maybe it's
I definitely wake
fun.
up wanting to go to work more than I did the last 5 years.
Because it's in your blood.